Welcome to this webinar that will review certificate of capacity inconsistencies as demonstrated with a low back pain case study. For over 10 years, I've been running a low back pain case study with various groups, including medical practitioners, physiotherapists, insurers, and employers, to see how the group would certify the case. This case study was originally developed at InjuryNet Australia and has since been used in a variety of settings, both here in Victoria and nationally. A striking observation is to see the variability that can exist in how different groups and within groups can certify the same case. You'll get a sense of this in just a moment. The case goes like this. There's a 45-year-old male who works as a supply chain storeman. The physical demands of the job include constant standing and walking, frequent stepping on and off equipment, squatting, bending and twisting. There's also constant lifting of up to 19 kilograms with an average weight of 13.5 kilograms. There is a 2-day history of low back and right thigh pain. He's slowly getting sore and stiffer. There are no red flags or neurological problems. He's worse with sitting and better standing and walking. He exhibits overt pain behaviours. He had a similar episode 5 years ago, resulting in 2 months off work and resolving in 6 months. He's been fine up until this recent episode. This is a brief account, noting that more detailed information is provided during the actual training session. At the end of detailing the case, I asked the participants to complete a state-based workers' compensation certificate of capacity and to provide a diagnosis, to certify work capacity, and when they would follow up. Here is an example of what the participants would complete here in Victoria using the current certificate of capacity form. Marked in red on the front page is Section 2 for the diagnosis, Section 3 for the capacity assessment, and on the top right of the second page, Section 4, specifying the certification dates to indicate if the case is fit for pre-injury employment, fit for suitable employment, or no capacity for employment. The following graph gives an indication of how different groups certify this case as unfit for any duties. Rather than using the term no capacity for employment, as the Victorian certificate states, I'll use the terminology unfit for any duties in this case as the results are across different states and different types of certificates. The first bar indicates that 6% of trained practitioners certified the case as unfit. The training they received had an emphasis on evidence-based practice and early return to work. The second bar indicates that 23% of keen physios certified the case as unfit. I call this group the keen physios as they had an interest and experience in working with compensable cases, had not had formal training on certification and return to work, but were about to undertake a program as part of WorkSafe Victoria and TSC's occupational physiotherapy program. As you can see, some variability in how the case is certified is beginning. It was considered that the result could be a reflection of untrained providers who do not routinely issue certificates. In the third bar, 34% of general practitioners in Hobart certified the case as unfit. This group of practitioners had an interest and experience in working with compensable cases and issued certificates on a regular basis. Interestingly, the regular certification did not improve the rate of being certified unfit with this group. Finally, the fourth graph continues this upward trend with 72% of general practitioners certifying the case as unfit. This group was located in regional Victoria where many general practitioners in that area would routinely issue unfit certificates. What this exercise highlights is the same case can be certified differently by different practitioners in various locations. Managing the variability will be addressed in the other webinars in this series. In addition to seeing if the case was certified fit or unfit, we also looked at the certified capacity and restrictions. These results relate to the first bar in the previous graph where only 6% were certified unfit and 93% were certified with capacity and restrictions. Interestingly, 1% deemed the case to be fit for pre-injury duties. The most common restriction noted, with 91%, was a weight restriction. Here the variability is demonstrated again, with the lifting range from 0 kilos to 16 kilograms, with an average of 5.4 kilograms. Although it was noted in the case that sitting would make the symptoms worse, only 47% restricted sitting. This means that 53% would return to work and not have limits to their sitting, which would pose a problem if sitting was then deemed a suitable duty. Again, variability was noted with a sitting range from 0 minutes to 240 minutes, with an average of 21.3 minutes. 63% of the participants limited bending, and a variety of other restrictions were also noted, such as twisting, specific jobs, having rest breaks, doing job rotations, and limiting stairs and ladders. My personal favourite was certifying that the person could work and chat to people at work, make coffee, etc. As you can see, certification is not an exact science, and that many factors can influence certification, not just the presenting injury. It also demonstrates that inappropriate certification can be a primary return to work barrier. Work needs to be done to improve accuracy and consistency in certifying, and these webinars are a step in that direction. We hope you enjoyed the webinar and you have a look at the others in this series. Remember that due to the physical, psychological, and social benefits, we really should see return to work as treatment rather than a goal of treatment.